It's really a great privilege and honor of mine to bring forth a new visiting professorship that we were able to arrange this year. The Baszucki family, for the handful of video gamers in the room, should be a familiar name. Paul Baszucki, who happened to be one of our patients and a grateful patient, at that, was the original sort of investor into his son's company, small company called Roblox, that again, the video gamers in the room might know. This is David Baszucki and his wife, Jan, that runs the foundation, along with a couple of their other kids, Greg and Todd, that we've gotten to know over the years. And through a very grateful donation from them to really fund a vascular surgery research consortium, as well as a visiting professorship. We at the Department of Surgery and the Division of Vascular Surgery are, absolutely indebted to the Baszucki family for their generous.
Yeah, I'm Paul Baszucki, 81. Had my aneurysm repaired at 79. I feel terrific. Happy to be back. You can see my garden in the background. Very active gardening and golfing, and life is great. Thanks very much.
So what we did with the gift, and folks have heard this before, Najeesh Syed, one of our co-directors of the Baszucki Biobank, I gave grand rounds last year. Many other biobanks exist, provide valuable data, and what we wanted to do was turn it on its end a little bit, in that many surgeons will have insight into the subtle clinical phenotypes and have access to daily tissue, since we operate every day. And particularly within our specialty, you have access to a wide variety and geography of tissue throughout the human body. And folks that know our group and the ability for us to recruit talented faculty, we certainly have unique resources and a significantly collaborative team with our vascular medicine colleagues, with cardiology, with cardiovascular medicine, as well as with multiple other members in the Department of Surgery. We wind up having a wide variety of complementary sort of expertise in so both AI, machine learning, clinical informatics, genomics, vascular stem cell biology, cost-effectiveness, health policy, the contributions of Aspire to our group, image modeling, working with bioengineering, observations made related to complex clinical care, as well as the significant interest of Stanford medicine in clinical trial development. So these are all things near and dear to vascular surgery, and why this was such a great contribution from the Baszucki family. So I think that the people in the back row know sort of about the 6 Ps of sort of acute limb ischemia. So we've also added then sort of the 6 Ps of why Biobank: progression, prevention, personalization, precision, prognosis, and policy. And these are kind of the hallmarks of what we've been trying to do related to vascular disease and how we move forward. So we had a wonderful event the last 2.5 days with our visiting professor. The family has come out, spent some time on Sunday evening with a barbecue. Yesterday, we had a significant research consortium, visited the lab. The family was particularly interested in all of the freezers that we've sort of garnered, and the space that we've garnered, some of the bench space that we've had here. The labs of Dr. Syed, and sort of in that region, Dr. Leeper there, but really the contributions of Derek Claren, one of our other co-directors of the Baszucki Biobank. And so as we thought about a visiting professorship and who we should bring on board, it was clear that our first inaugural Baszucki visiting professor should be somebody that's been sort of interested in sort of genomic-wide research, things that having tissue can really contribute to, and looking at large-scale populations of how we can understand some of the basic mechanisms of vascular disease. Scott Damrauer, who's our visiting professor, has spent most of his early training at the other Stanford on the East Coast, did his undergrad at Harvard, did med school at Harvard, did surgery residency at the Massachusetts General Hospital, spent his T32 at the BI Deaconess, and then for his vascular surgery fellowship, then went to the other Stanford of the East, to University of Pennsylvania, where he did his vascular fellowship there. I've personally tried to recruit Scott multiple times at each of those phases over his career. And so at least finally we're able to come get him out here to be a visiting professor. He's certainly within our field, one of the top researchers, really has risen through the ranks there. Runs a genetics lab, has collaborated with so many people that are a part of Stanford medicine. And we were just absolutely delighted that he accepted our invitation to be the inaugural Baszucki visiting professor. So without further ado, I'd like to bring up Scott Damrauer from University of Pennsylvania. Great, thanks.
Good with this. I have this guy on, I'm good. Okay. Huh. There we go. Okay,
All right.
great. Well, thank you for that really kind introduction, Jason. It's finally, it's nice to be out here speaking at the University of Pennsylvania of the West. Yesterday was a really, really impressive day, a very interesting day and a fun day hearing about the work you have going on in the division here that's being done by your faculty, your residents, your students, and really sponsored by the Baszucki family. So it's a really impressive program you guys have built out here. Today, I'm going to be tackling in this talk kind of I think it was your third and your fourth P, precision and prevention, and how we as surgeons can think about implementing precision medicine for the care of our patients. I'm really going to focus on two things, kind of where are we going? So like, what is this endeavor of precision medicine? What does it offer us? What are our kind of wide-eyed and bushy-tailed hopes for the future? And then kind of where are we? And is that going to turn into a reality? These are my disclosures. None of them are really relevant for what I'm going to be talking about today. And so getting into it, where are we going? I think precision medicine means a lot of different things to a lot of different people. And at some levels, a little bit hard to define. I think there are a number of endeavors that we undertake as physicians and surgeons that are well suited to application of what we call precision medicine. So one of the fundamental challenges we face is when looking at a large population of individuals, identifying those that are either increased or decreased risk of having a disease so that we can offer them the appropriate primary or secondary prevention or treatment opportunities, be it screening, be it intervention. A second endeavor that we face is when looking at a patient in front of us in the office. It would be great to, shake our magic 8-ball and figure out if the gentleman who has an abdominal aortic aneurysm at 58 is going to rupture at 64 or be totally healthy at 97. So this idea of understanding disease prognosis. And then finally, trying to differentiate between subtle forms of the same disease to offer personalized care. And so sometimes that's really easy to spot the disease that stands out. And sometimes it's a little bit harder to differentiate between the two. So if you're looking at the only two differences I've found so far is the time on the clock and the number on the front of the buses. My guess is there's probably others, but there was kind of a limited amount of time I was willing to stare at that. So I think precision medicine is well suited for achieving these three primary goals of like our entire endeavor. That being said, I haven't really told you what precision medicine is, and I think it's a little bit elusive at times to define. This is probably the best definition I've seen, which comes from the National Human Genome Research Institute of the NIH. It's that precision medicine uses information about an individual's genomic, environmental, and lifestyle to provide a more precise approach for the prevention, diagnosis, and treatment of disease. And I think it hits on both the inputs to precision medicine and the application or outputs. So with that, I think the question becomes, are we there yet? And how close are we to achieving what we're hoping for? So I'm a vascular surgeon. The key focus of my research program is to try to understand why people get heart and vascular disease, and to do that using humans as a model organism. And so most of, if not all of the examples I'm going to give you really are situated in the heart and vascular disease space today. At the end, recognizing this is general surgery grand rounds, I'm going to pivot and talk about precision medicine for diverticulitis, which is actually the work of one of my friends and colleagues, Dr. Lily McGuire, who's junior faculty at Penn and is kind of absolutely brilliant. And so we'll hopefully get to that. So one of the main endeavors in which we kind of treat cardiovascular disease is risk prediction. And this is really central to how we approach atherosclerotic vascular disease. For those kind of not familiar with this endeavor, we're pretty good at it. So we use something called the pooled cohorts equation, which takes into account kind of the general risk factors that we all acknowledge for atherosclerotic vascular disease. So age, sex, race, cholesterol, blood pressure, whether you're getting treatment for your high blood pressure, diabetes, and if you're smoking. And for individuals who are 50 or older, and that's like an important part of this, it computes a 10-year risk of having major adverse cardiovascular events. So heart attack, stroke, cardiovascular death. Based on your risk, you then kind of go into this algorithm on the left, which is from the AHA and ACC, which sorts you into a bucket and tells us what to do with you. And essentially, the main intervention here is putting you on a statin or not. And using this approach, and really with the introductions of statins and high-intensity statin therapy, we've driven down the rates of major adverse cardiovascular events over the past 30 years. However, something interesting happened in 2010, and over the past decade or so, we've seen an increase in the rates of cardiovascular death in the United States, suggesting that something about this endeavor is not quite right and may not quite be enough to solve the problem. So this gets at how we measure and predict risk. This is not the pooled cohorts equation. This is another equation called Q-WIT risk 3. Same general principle, different set of risk factors. This is kind of more calibrated in the United Kingdom. But what I'd point out is that when you look at how this model performs, the R squared, or the amount of variance the model explains, is only about 50 to 60% of the disease. So something about our risk prediction endeavor is failing, and we're not getting to where we need to be. So how can we improve risk prediction? And not surprisingly, this being a precision medicine talk and me being a cardiovascular geneticist, part of the answer is through genomics. So for those of you not used to looking at this type of graph, this is a results of a genome-wide association study presented as what we call a Manhattan plot. Across the x-axis are all of these DNA variants plotted as dots, essentially in the order they appear on the chromosome. And on the y-axis is the significance of their association with the outcome of interest. This happens to be the GWAS results from really the first one of these we did in MVP on peripheral artery disease. And I just put it up here because it illustrates a few things. Even the strongest risk variants, here a single variant in LPA, only have an odds ratio of about 1.26. So, in the common variant GWAS literature, that's huge. In the scope of everything else, that's pretty small. And then a lot of the ones that still pass our level of significance are down at 1.05. But as you can appreciate, there's a heck of a lot below this dashed red line, which we're kind of arbitrarily calling significant, and 0. And that information, there are ways to leverage all of this to help us predict disease. And so what we can do is we can sum up all of that genetic variation into something we call a polygenic risk score. This essentially takes all of the DNA variants, says what ones do you have, multiplies them against the impact they have on disease, and gives you a score. We can then scale it and make a distribution and ask, how do people in one end of the distribution compare to everyone else? And this has been done for a whole host of phenotypes. One of the ones that's been most extensively examined is coronary artery disease, and some of the areas in which this was described from the beginning. So if we look at grouping people based on the percentile group of their polygenic risk score for CAD, you can see that as you go to higher percentiles of risk, your risk of the disease increases, so much so that if you get into this top 2.5 percentile, the odds ratio for having coronary artery disease is about 4. This is shown another way with a slightly different method of calculating the risk score. And you can see that if you look across percentile bins, so here colored, and you look at years, the cumulative risk of CAD increases in the higher percentile risk bins. And this is data, and these are two of them among the founding papers in the field describing this phenomenon. And we've seen it apply to a whole host of other diseases. So early on, we were interested in applying this in some real world examples in data we had access to, which was the Penn Medicine Biobank. This is a relatively diverse cohort, currently of about 250,000 individuals. When we did this experiment, we had 12,000 individuals with genetic data. About 23% of that was African-American individuals. This was work that was done by Mike Levin, who's now a junior faculty cardiologist at Penn, but at the time was a internal medicine resident in my research group. And what we did is we took individuals who came to coronary catheterization. So these are people in who not only did we have all of their risk factors, we actually knew what their coronaries looked like. And we asked, if you control for all of their risk factors and what their coronary arteries look like, does a polygenic risk score associate with outcome? And what you can see is individuals who were in the high PRS group, denoted in blue, had a significantly increased risk of mortality moving forward. And so we thought this was pretty profound data, that this polygenic risk score has something to add to risk prediction. And you can see here that holds whether you break it down as to whether the people had no angiographic disease, non-obstructive or obstructive disease. And in follow-up work that we did with investigators both at the Broad Institute and at Mount Sinai, we showed that the risk captured by a polygenic risk score is orthogonal to the risk captured by the pooled cohorts equation. So here we're comparing individuals in the top 20% of risk and individuals in the bottom 80% of risk. And what you see is if you look at those groups separately and ask how do they compare on traditional measures of risk, they look exactly the same. And so something about this polygenic risk score, which we know associates with disease, is capturing something different than what we see with traditional methods. So Mike went on to do some really interesting experiments using a technique called genomic structural equation modeling, which for the sake of time, I'm not going to get into how it works. Suffice it to say, what it allows you to do is to take a trait you're interested and then ask how it relates to a number of associated traits that you also know, both with respect to the correlation. So these are correlation coefficients here, they're R's. If you want to know the contribution of those to CAD, you have to square them in your mind. But the take home is after you control for all of that at the genetic level, there's still 66% of the genetics of CAD that's not accounted for by any of the risk factors. And so that perhaps is what the polygenic risk score is capturing. If we look at the genetics of CAD as a whole, and you read down these pathways that are enriched, it's essentially cholesterol metabolism is like the leading thing that causes CAD. If we pivot to the residual risk, so that's the CAD I showed you minus all of those risk factors, you start to see some interesting things like histamine uptake, neurohormonal axis, serotonin, epinephrine. You still see some lipids, you see some blood vessel development. So you see a lot of processes that are not in that other list, but that make sense. So this may be what we're getting at with the polygenic risk score. This was all fine and dandy until people got much more sophisticated with the epidemiology. And I think this is an important methodological thing to think about. Most of the work with polygenic risk scores has historically been done using epidemiological models that we leverage for most of the studies we write as surgeons. So these kind of, I want to test the association of X with Y, and not using what is probably the right approach for this type of work, which is predictive modeling. And so in predictive modeling, you don't necessarily care about the association. What you care about is model fit, model discrimination, model calibration. And when people started asking these questions using really, really good cohort data sources, the answers started coming out a little bit fuzzier. So within like the same version, the same issue of JAMA, there were these two papers published, and then followed up by this review at the bottom, this editorial at the bottom, really starting to say, well, maybe these polygenic risk scores don't actually accomplish anything and don't improve our ability to predict coronary artery disease. And so that raised a lot of question about what the utility is. To to highlight that point, I'm going to use yet a different paper, which is one that I've had the privilege of being involved with using data from the VA. It's very nice because it's a lot of data, it's a lot of veterans, it's larger than either of those two studies, and it's extremely diverse with respect to ancestry populations of the participants. This was work that was led by Jason Vassy at the Boston VA and overseen by Peter Wilson at the Atlanta VA and Emory. So what they did is they compared in a prospective cohort of 137 veterans enrolled in the VA Million Veteran Program who didn't have any evidence of CAD when they enrolled. They compared the ability of the pooled cohorts equation to the pooled cohorts equation plus a CAD polygenic risk score to predict incident CAD. So don't have disease when I start, do I get disease in follow-up? And they looked at 5-year risk greater than 3.75%, which is kind of getting you into that moderate level of risk, and ask, is the net reclassification index different? So this is a metric that says if I use score 1 and I use score 2, do I move people from one classification to the other? And what you see is across all ages and across all ancestry backgrounds, there's really, while a minor significant, statistically significant improvement, a practically null result. So this is one of those like, yeah, it's a large study, the error bars are small, the result doesn't overlap 0, but like in reality, that's a really precise estimate of a number that's very close to 0. And then they looked, broken down by age groups. And this is interesting. I just want you to remember it. If you look in the less than 40-year-old age group, it looks like there's a hint of a signal here. The error bars are wide, but you start to see some benefit if you're willing to ignore the error bars. And we're going to come back to that. So I think this very nicely convinces me, at least, that there's probably not a huge role for polygenic risk score in improving risk prediction for CAD and MACE in individuals who you can use the pooled cohorts equation for. So what about AI and machine learning, right? That's like the future of the world is AI. So we tried to answer this question using some different data in a somewhat similar study design in collaboration with investigators at the VA. It was essentially very similar. We had a slightly different number of patients, but we identified individuals who were free of cardiovascular disease and not on a statin, because that's really who you're interested in when they enrolled in MVP, and asked what happened to them over time with respect to cardiovascular disease outcomes. We first restricted ourselves to the same risk factors that were in the pooled cohorts equation and said, does machine learning help us? And the answer there is no. And so this is the area under the curve, or how well a Cox model works. And you can see that none of these machine learning approaches really did any better than a traditional Cox model for predicting incident disease when we gave them the same risk factors. We then said, let's open up the space and use essentially every diagnosis in the EHR the patient has up into the time they enrolled, every lab measure they have, and try to predict disease. So the first thing that happened, because you can tell it's not on the graph, is the Cox model failed to converge. It gave up. We managed to get a logistic regression model to converge, but it did horribly. And then essentially all of the machine learning models did both statistically significantly better and actually better, suggesting that the role of AI and machine learning here, it's not magic. It just handles a lot of predictors a lot better than our traditional regression models. We then ask, does genetics improve this? So, and in this case, I'm sorry, this is the same thing, just shown a different way. So these are the AUC curves, and you can see that kind of this ensemble model in red outperformed Cox and PCE using the risk factors that were plotted into them. You can, one of the concerns with AI is you can't explain it, you don't understand what's going on. That's actually totally wrong. They're very explainable models. So we can look at the impact of risk factors at the population level as a whole and try to see, okay, lower age is associated with protection with disease, and kind of how these variables interact at the population level. We can also drill down to the individual participant level and say, using an AI model, can we explain that individual's risk? And we can put together for that person what the list of risk factors are, or the most influential risk factors that got them to their own risk estimate. So it kind of does do these things that make it that we think are important in our ability to communicate risk models to patients. So then we asked, if we add genetics, do we improve beyond this? And hopefully what you can appreciate is there's in fact two AUC curves here, one for a PRS for the best performing machine learning model, and one for the best performing machine learning model with the polygenic risk score in it. And those curves are exactly on top of each other, meaning the polygenic risk score or the data doesn't really improve upon this expanded model that considers a lot of phenotypes. And we looked at this whether or not we gave it a polygenic risk score or whether we just gave it all of the DNA variants and let it do what it wants. So I think this highlighted a number of points to us. Essentially, the more data you have, the better. And that, once you have a lot of phenotype data, you may not get a lot from genetic data. So where does PRS have something to offer? Because I think it still has a place. And so if you remember, I showed you this before, that in this early age group, there seems to be some net reclassification benefit, although we don't see statistical significance. And this is not all that surprising because the pooled cohorts equation isn't really set up to be used for individuals who are less than 40 years old, and really isn't very well set up for individuals less than 50. And so is there a population that we can use this risk score for in whom our traditional models don't work and might be able to predict an increased risk of disease that's not evident in the risk factors they have at the time we see them and lead us to intervene? This is the same type of data from a different study. This was done in UK Biobank. And so they looked at a polygenic risk score and its net reclassification by different age groups. And you see some sense potentially of a benefit in the youngest age group. Looked at a different way, they binned people by polygenic risk score and looked at their cumulative incidence of disease over time. And this is among the younger individuals, and see that those curves do begin to splay out based on polygenic risk score over time. So I think there is a clear application in younger individuals in identifying those that may be at risk. The second is stratifying therapy based on polygenic risk score. So this is a post hoc analysis of the Odyssey outcomes trial, which randomized individuals into alirocumab or placebo. Alirocumab is a highly potent PCSK9 inhibitor that essentially makes your LDL cholesterol zero for all practical purposes. And that you see there is a larger absolute benefit of the drug marked by time to incident cardiovascular events among those who are at high genetic risk as compared to those that are at low genetic risk. And so this would suggest that if you have a really expensive therapy and you want to try to decide who's going to get the most benefit, you may be able to use polygenic risk scores to do that. The third is to motivate behavior. So this is work by Eric Topol from Scripps. They came up with an app that if you subscribe to 23andMe allows you to log into your data, calculate your polygenic risk score, and returns it to you, and then ask people about their responses to that data. And what they saw is that individuals who were at higher risk for coronary artery disease were more likely to make changes in either their diet or to actually take their statins that were prescribed, and more likely to go talk to their doctors about their genetic risk than those that were at lower risk. And so I think there's evidence that we can identify people early, that we can tailor therapy, and that it impacts what they do. And that's in the setting of a disease in which we're really good at predicting, or we think we're pretty good at predicting who gets it. So switching to a disease that is perhaps nearer and dearer to my heart as a vascular surgeon, and I know is very near and dear to the heart of the division here, abdominal aortic aneurysm, right? So we screen people for abdominal aortic aneurysm with the idea of identifying early, following it over time, and then intervening when we think the risk of intervention is less than the risk of the aneurysm rupturing. Based on a lot of policy work, this has resulted in both Medicare policies and VA policies that extend screening to mostly men who are 65 to 75 who have ever smoked, or women or men with a family history. This is a slide that Liz George in the division here gave me, and she showed yesterday during a wonderful talk on kind of policy and the work she's doing in vascular disease policy. This is from an analysis of VQI data, so our major societal database, that shows only 40% of those individuals who are diagnosed with the AAA were actually eligible for screening. And so our screening algorithm is missing the vast majority of cases. So we asked, can we improve upon this using genetics? So based on an early GWAS we did of AAA, we elaborated a number of different polygenic risk scores that differed based in their complexity and tested them in data from the Mayo Clinic, so a totally separate data set. And we see in each case, the polygenic risk score associates rather strongly with having an abdominal aortic aneurysm. We then controlled for kind of the leading risk factors for AAA, so ever smoking or having a family history of AAA, or both of them together, and we still see a strong association with having the disease. And then we went and tested that in a number of other external data sources where that was not derived from and not evaluated in, and see the same phenomenon. So we hypothesize that we can use this to better identify individuals who should be screened for AAA. So currently, as I said, we screen men aged 65 to 75 who ever smoked. This is largely based on RCT data that suggests that once you have a baseline population prevalence of AAA of about 6 to 7%, your screening endeavor is cost effective. If we look at incorporating a polygenic risk score, what you see is basically if you take the top 5 percentile of everyone, you get to 6%. In the top 5th percentile of men greater than 50, you get to 9% population prevalences of AAA. So rather than using the approach we use now, you could just say, if you're in the top 5% of polygenic risk, you should get a screening duplex. And we would do at least as well and potentially better and screen more people. Obviously, this needs kind of like real world evaluation, but I think is pretty exciting. We've also done similar work for thoracic aortic aneurysms and dissections, showing that a polygenic risk score not only associates with prevalent disease, it associates with incident disease, and it associates with death from thoracic aortic aneurysm and dissection. So what is the future of risk prediction? I think it's going to be population-specific models using expanded feature sets and machine learning and polygenic risk scores for select cases. I think polygenic risk scores as a whole may have little to offer, and this is a little bit controversial, for areas where you already have a good risk prediction algorithm. And so I think you have to look at where you're starting from and where you're trying to get to. And then there's a third piece of this that we're not going to talk about, which is the heritability of the disease, how big your GWAS was for the disease, and how good you know the genetics of the disease. And it's not going to be like this is a panacea for everyone. There's going to be select cases where it's useful or not. So that covers kind of the prediction and the prognosis part. I want to switch to talking about precision therapy. So the mainstay of both primary and secondary prevention is targeting these. I think this was Life's Essential, Life's Simple 7. I think we're now on to Life's Essential 8 because we added sleep to this. But this is kind of how the AHA says we should address atherosclerotic cardiovascular disease, as you know, and it really looks at heart attack, peripheral artery disease, and stroke and treats them equally. You know, in terms of addressing just the lipid piece of this, as well as the thrombosis piece of this, we have a ton of different medications, some of which you're probably very familiar with: statins, PCSK9 inhibitors, aspirin, Plavix. They've been around for a long time. With the exception of PCSK9 inhibitors, they're relatively inexpensive. In the scope of emerging therapies, PCSK9 inhibitors seem like a bargain at $15,000 a year. There's a lot of really exciting work being done on targeting triglyceride-rich lipoproteins, which estimates suggest, you know, to get on one of those therapies, you're talking between $500,000 and $750,000 per person per year. There's exciting work on lipoprotein A, which kind of back of the envelope calculation suggests those therapies may be about $300,000 per person a year. There's anti-inflammatory regimens that have pretty significant, you know, downsides and side effects of targeting IL-6 and IL-1, both in terms of personal risk and in personal pocketbook. Again, you know, pushing up to $500,000 a year. So trying to figure out who to use these in probably makes sense rather than just saying, it's everyone with cardiovascular disease. Although I guess if you own stock in any of these companies, you may just say it's everyone with cardiovascular disease. So I think where some of this opportunity is in recognizing that these three diseases, which comprise atherosclerotic cardiovascular disease, are probably not the same. They're probably different diseases. And there are techniques that we're using in genetic epidemiology to try to address this. There's an approach called Mendelian randomization that essentially simulates a clinical trial and uses the genetics to allow you to ask how a non-genetic risk factor relates to a non-genetic outcome. And kind of for the sake of time, we will spare you both the theory and the math behind that, but essentially it's a form of instrumental variable analysis. We use that to look at the role of the traditional risk factors comparatively on PAD and CAD, and see certainly that things like LDL cholesterol and diastolic blood pressure have a greater effect on coronary heart disease, and things like smoking and diabetes seem to affect PAD slightly more, again, suggesting a tailored approach makes sense. We can go on to use more advanced forms of Mendelian randomization to ask about correlated exposures. And here we're using a Bayesian approach and looking at the relationship of the different lipid species to PAD and CAD. We see for both of them that ApoB-containing particles is the primary causal lipid fraction for the disease. But when we look at what ApoB-containing particle it is, we see that they're slightly different. So for PAD, we see the prioritized causal particle is this extra small VLDL, whereas for CAD, we see it's large LDL. And you might be saying, what's the difference between extra small, very large lipoproteins and large lipoproteins? But in fact, we do think about them a little bit differently. And these extra small VLDL components really comprise more of a triglyceride-rich lipoprotein component. And there's some thought that some of these newer drugs may be more efficacious for targeting this lipid fraction than others. And so you may not want to just blindly apply them, but really think about what diseases people have. So as much as I think this is the way that we need to think about it, or are starting to think about it, I would say this is probably the way that we really need to think about it, which is it's not just that CAD, PAD, and stroke are different. It's that CAD, PAD, and stroke in different people are different. And I think the oncologists and the surgical oncologists in the room are probably familiar with approaches where you take tumor and you don't say, oh, this patient has non-small cell lung cancer. You say, this patient has a non-small cell lung cancer with these mutations in it, and therefore they need this highly specific targeted therapy. And we found that actually has really changed lung cancer treatment. So I think there are approaches to this in cardiovascular disease. This is one that's been put forward by Andy Buechler, who has a company in Boston, but this was from his PhD defense, in which they're using CT scans of the carotid to dissect out the components of the carotid plaque in a way that correlates with histology, that correlates with gene expression, that they then can apply systems biology to and try to identify for an individual person, is it the inflammatory axis, is it the thrombotic axis, is it the lipid axis that needs to be addressed in order to intervene? Thinking more surgically, if that worked or not. This is try to get the animation to work here. This is a slide that Ken Tran in the division here kind of kindly loaned me from a great talk he gave yesterday on applying advanced imaging techniques to aortic aneurysm repair and modeling. And you can imagine a world in which you use these approaches to take a patient's data, to make simulations, to understand what's going on, how it's going to behave when you put a specific graft in it, and then to come up with a really informed solution to the patient, rather than saying, well, this is the device that I like to use, and this is the size of the device that fits in this patient, right? I like, Levi jeans, and we're going to go with a 32, 34 here, to really saying, let me tailor something custom for this patient. We're not quite there yet, but it's a matter of time. So I think there is this future of precision medicine for therapeutic selection, in which we use disease-specific paradigms for risk factor management, for pharmacological management. We use non-invasive methods to assess patients to come up with tailored therapy, and then we develop patient-specific anatomy and physiology approaches to intervening as surgeons. We're now going to totally switch gears away from cardiovascular disease and talk about the role of precision medicine in surgical decision-making. Again, this is work that the only role I have in this is Lily McGuire, who's brilliant, is a good friend of mine. She is part of our research group at Penn, and we have, after recently successfully recruiting her. So, she is a colorectal surgeon and she studies diverticulitis. Diverticulitis needs no introduction or background in a room of general surgeons. If you're wondering about it, you might need to reassess what room you're in. Anyways, we know that diverticulitis can be a recurrent disease, And according to the American Society of Colon and Rectal Surgeons, we've moved from, what I learned or Dr. Lee learned or Dr. Hahn learned when we were residents, which was like 2 bouts and then you take out the colon, to this much more individualized approach to what to do, right? The main treatment for diverticulitis for secondary prevention is to remove the sigmoid colon. And so again, it used to be second bout of uncomplicated or first bout of complicated diverticulitis, book them up, take out their colon. Now it's much more individualized. The problem with that is like, what does that even mean and how do you do that, right? This is not a non-morbid procedure. These numbers are small, 0.5% mortality, but it has 23% morbidity. It's not nothing to lose your colon. Yet diverticulitis is pretty bothersome too. And how do we balance overtreatment and undertreatment? So Lily's answer is genetics. In 2018, she published a really nice genome-wide association study of diverticulitis in the UK Biobank. She found 39 susceptibility genes for diverticulitis, which you can see here. And then not surprisingly, she subsequently used this data in a very nice paper in the Annals of Surgery to look at its ability not to just predict diverticulitis, but to predict diverticulitis severity. She took her polygenic risk score and she applied it in the Michigan Genomics Initiative. So this is similar to the Penn Medicine Biobank. This is a collection of individuals in Michigan. She, among people who had diverticulosis or diverticulitis, categorized them based on really deep analysis of the electronic health record as to having asymptomatic disease, so diverticulosis, mild disease, so outpatient treatment, less than one or less inpatient treatments and no procedures, or severe disease, meaning they had surgery, they required a Jane, or they had multiple inpatient admissions. And then she asked across this group, what are the rates of either mild or severe diverticulitis by polygenic risk bin? So she binned people into 10 deciles of risk. And you can see that as you go across the bins, those in the higher decile have a higher rate of overall diverticulitis and a higher rate of more severe disease. So maybe we can predict severity. She then used multivariable models that adjusted for age, sex, and BMI, and compared those in this experiment at highest risk, so top 10 percentile, to those at a less than 50 percentile risk. And what you see is it increases your having this top decile of PRS for diverticulitis increases your risk of having any type of diverticulitis by about 84% relative to those that are at low genetic risk. She then went on to ask about the association with severity. So again, comparing the top 10% with the bottom 50%, you see about a 61% increased risk, and this was significant. But she's cheating, and she cheated on the last slide. This idea of comparing the total top to the total bottom is probably not what you want to know. What you want to know is, can you isolate a population from everyone else that has increased risk? And so she looked at the top 10% compared to the bottom 90%. And while she sees a trend, it's not statistically significant. It almost certainly is a power issue. And so that was a little disappointed. But you can flip the question on its head, right? One approach is, you're in my office, I want to predict whether or not you have diverticulitis and know whether to take your colon out. Can I say you're at high risk? And if so, do it. Another approach is to say, can I tell you that you're at low risk and you don't need to worry about it? And so she went and compared the bottom 10% to the top 90%. And here she saw that being in the bottom 90% resulted in a essentially 60% reduction in your risk of having severe disease. So, this idea that you don't have to predict high risk, sometimes it's as valuable to predict low risk. So I think exciting results. She did along with this, you should look at the paper, it's wonderful. A discrete choice experiment to try to understand in what cases colorectal surgeons thought this would be useful. And it really was what you would think, people who are kind of in the middle, who it wasn't obvious. She's continuing on to expand upon her GWAS, which will undoubtedly improve the performance of her polygenic risk score. And these are kind of her most recent results, which I think are getting presented by one of our general surgery residents, Chris Nyland, at the American College of Surgeons this year, in which they expanded to use data from the VA Million Veterans Program and identified 284 risk loci from like 40. So chances are you use this for a polygenic risk score, you're going to significantly improve upon what you're seeing before. And this gets at the idea that another component of this is both the heritability of the disease and how much of that heritability you know. So I think overall, there's reasons to be hopeful for precision medicine in both medicine and surgery, but it really depends on matching the right approach to the right disease and then doing that in the right patient population. So with that, I'm going to conclude, and I'm happy to take any questions.